All these things are related to that word. Okay. The stomach is a dilated sac of the upper GIT. As you know that from the oral cavity, the dilated oral cavity leads to a constricted part which is called the esophagus. The esophagus lies in the posterior mediastinum in the thorax, and then it will pierce the diaphragm to enter into the abdominal cavity. When it pierces the diaphragm, it is being slightly deviated towards left. Starting from the midline, it is slightly deviating, shifting towards left to get open into a dilated sac which is called gaster or stomach. The stomach is not only dilated, but it is during the early developmental phase. This dilated structure is being shifted or being rotated towards the left side. Initially, this tube was in the midline. Throughout tube is in the center, but some areas they would be rotated. And this rotation, actually, this stomach was initially in the midline, then it is rotated like this. And this rotation would accompany the stomach within the undercover of the lower rib margin. The area of the abdomen below the costal cartilages and the ribs is called hypochondrium. So naturally the hypochondria are divided into two. One is left hypochondrium and the other is right hypochondrium. In between the two hypochondria, just below the xiphoid process, the sternum, there is an area, triangular area, which is called epigastrium. So, some portion of the stomach and the accompanying structure closely related to the stomach, the liver, is being close relation with each other in the epigastric region. Understand? So, this structure is being shifted towards left, lying under the cover of the hips, most of the portion, and this is having an upper end and a lower end. The upper end is more dilated, it's more dilated, the lower end is comparatively not dilated. This is the remnant part of the esophagus, which is opened into the stomach by means of this tube, this area. The stomach starts from the esophagus by means of a specific junction which is called Z-line. What is it called?
Z-line.
Z-line. The Z-line is a serrated edge which you can see here, the folds, and these folds, they distinguish the boundary of esophagus from stomach.
What you can see?
Inside there would be a Z-line, you see, that is actually the transformation of one epithelium to the another epithelium. In the esophagus, a stratified variety of the epithelium, and the stomach, simple columnar epithelium. The junction between these two different epithelium is being identified as a Z-shaped structure. This is being guarded by means of the circular muscles, and this forms the lower esophageal sphincter. What is it called?
Lower esophageal.
LES, lower esophageal sphincter. Normally there is a good tone in the lower esophageal sphincter, but when in certain cases of more pressure within the abdomen, like in repeated pregnancies, like in other cases where the abdomen is having raised intra-abdominal pressure, this will lead to the lessening in the tone of the lower esophageal sphincter. What would be the complication, that lower esophageal sphincter never allows the food material to move back, regurgitate up. So in case of the less tone of this area, there would be regurgitation of food when the patient is in recumbent position.
What do you call it?
Regurgitation. Okay? So regurgitation means introduction of food material, again instead of going front, down, it's going up. Yeah, so that results in complications and all different pathologies. So this end of the stomach, as it is closely just above to it is the heart. So this end is called cardiac end. What is it called? Cardiac end. The cardiac end below is the pyloric end. Okay? Between the cardia and the pyloric end lies two structures, that is a dome-shaped thing which is called fundus, and below the fundus is the body, and here is the antrum. So the most important thing which is closely related to it would be the fundus, in which the gases will accumulate and the rest of the area is being occupied by the food particles, food material. Gases lie in the fundus. Whenever in erect posture, if you go for the barium meal and follow through, the black shadow will lie in the fundus area. Okay, and the barium salt will trickle down and forms a straight surface, gravitate down, and above it would be the black. So black zone up, white zone below.
How the gases can move out?
Yes, by means of eructations and by means of the gas may push down into the intestine. If they don't push down, then these gases will accumulate, and due to the release from here, that results in eructations. Okay? So you can see here that this is, you see the bag-like structure, dilated upper end, narrowed comparatively lower end, and it has got two surfaces and two borders. What are the surfaces? You see, is it a anterior surface or is this one is anterior surface? You will have to decide. How can you decide it? By means of placing it in anatomical position. If you place the stomach in anatomical position like this, definitely this would be the anterior surface and this is posterior. But if you are doing wrong, without identifying the anatomical position, you may commit a mistake like this. You may say this is anterior, this is posterior. Wrong. The stomach lie here in the left hypochondrium, so this would be facing towards you and this is facing towards the examiner.
Easy to identify the
Yes, anterior and posterior surface. So this anterior surface and the posterior surface, it's globular. You see, this is globular. And the two borders, one is short and the other is long. The long border starts from the lower esophageal sphincter. It moves up throughout the fundus, then the body, then up to the pyloric end. This this curvature is greater, so it is called greater curvature. This curvature is lesser. This is lesser curvature. And you can see one thing very prominent in this specimen, that the surfaces are being enveloped by means of a membrane. You see?
Yes.
A membrane is there. This is nude area. This is having no membrane inside. So this is having a membrane on front and on the back. But you can see there are no membrane. But instead there will be reflection of the membranes. A reflection of membrane from both curvatures. From the greater curvature also, from the lesser curvature also. One membrane which is formed by the greater curvature is called greater omentum. What is it called?
Greater
omentum. Omentum is related to the stomach which is nothing but it is the reflection of peritoneum. It is the reflection of visceral peritoneum. Got it? Peritoneum is a bag, balloon, which is being filled into the stomach, into the abdomen. So naturally, when this balloon, you see, when it is filled in a space and if you introduce a fist into it, the balloon, the walls of the balloon which is covering your fist is visceral. The neighboring inside the wall would be parietal. Understand? So, as this is a viscous, so the peritoneum which is closely related to the viscous is called visceral peritoneum. So, the greater omentum is the reflection of the visceral peritoneum from the greater curvature, and it moves, hangs down. It covers the front of your abdominal cavity, lies in front of the intestine. Similarly, another, you see, reflection is formed along the lesser curvature, and this will go up towards right, to go towards liver. This is called lesser omentum. Okay? Do you follow me or not?
Yes, yes.
So this is lesser omentum, this is greater omentum, and in between these two you can see the vessels are running. Actually the peritoneum, when it reflects, that means it will have to accommodate certain blood vessels, lymphatics, nerves inside it. You see, from the posterior abdominal wall, the major blood vessels are giving branches, and they will have to introduce into the abdomen by way of the reflection of the peritoneum. Okay? So you can see here in this view, the blood vessels, they are running in between the two shells, reflecting part of the peritoneum. So, when you go down, just open it in a longitudinal section, you can see two things very important. One is the periphery, the other is the central area. The periphery is being made by smooth muscles, a collar of smooth muscles outside. This will be having tone, smooth muscle tone, and this causes gastric emptying. Gastric emptying. You see, the food will enter from the empty. Khalas. Finish. You see, the stomach, the contents of the stomach will be
released.
When
لما الفود بينزل من السtomach يروح للintestine.
You see, the contents will be moving back and moving forward. Other thing which is closely related to it are the rugal folds. You see, there are elevations. You can see the mucosal elevations, and these mucosal elevations are called rugae. R-U-G-A-E. Rugae. Rugae are definite. We can see a specific pattern, very interesting specific pattern. In case of gastritis, in case of any inflammation, iltihab, you see that these folds, they disappear. And they become very red hot. You see, it's very hot, red hot, and the folds disappear. The important diseases related to the stomach are two, which you will have to bear in your mind. One is hiatus hernia, the other is gastric ulcer. Okay? Ulcer.
The first one. Doctor, you told us there is two important things in the stomach. Can you repeat it, please?
Yes. Outer is smooth muscle core. Inside is the mucosal folds. Okay? So
the first one. First disease, what was?
Hiatus hernia. Hiatus hernia. H-I-A-T-U-S. H-I-A-T-U-S. Hernia.
Can you explain the hiatus hernia?
Yes, in the abdomen. You see, there is these being demarcated by diaphragm.
Yes.
Some part of the stomach will enter into the thorax. You see, some part will enter, this fundic part will enter, squeeze up and enter into the thoracic cavity. And it creates pressure. As you know that the gas is filled in the fundus, so naturally the gas will move up into that closed space. And this will put pressure over the heart, and that leads to signs of angina. Very important to distinguish between hiatus hernia and angina pectoris. You see, ischemic heart disease. So this is a condition which is rolling and gliding variety. This is hiatus hernia, and the other thing is gastric ulcer. Ulcer is nothing but it is the desquamation of epithelium from any area. Whenever there is a cut, you may call it ulcer, because the cut means digging. You see, digging there. So due to the increased fatty contents, repeated bad dietary habits, that results in the excess production of acid pepsin, resulting in ulcer formation. Okay?
The physician, what can do in hernia of the stomach? Physician,
Yeah.
what can do in hernia of the stomach?
Hernia of stomach. Yes, he will have to open this anti-abdominal wall, and then he will have to pull the hiatus and just make a stitch around to keep it in the same position. Hernia means introduction of anything into an abnormal space. For example, if the chairs and tables are here for the classroom, if the tables and chair will be kept outside, useless, no use in the corridor. So we can say in terms of medicine, the tables and chairs gets herniated outside. You see, so this area will have to be inside abdomen, but in certain circumstances this will have to go up, not in the abdomen, in the thoracic cavity, where heart and lungs and major vessels are lying. So this is called herniation, and this herniation is called hiatus hernia. Okay, everything clear? Any doubt? Any query? Any question? Rugae. R-U-G-A-E. Rugal folds. They are called folds, elevations and depressions of the mucosa. Okay? Right?
That's it for the stomach?
Yeah. We here have to discuss with you related to the important parts, the location, the shape of the stomach, the curvatures of the stomach, the surfaces of the stomach, the ends of the stomach, inside the stomach, and the peritoneal reflections, greater and lesser.
What about the supply?
When we will do the celiac trunk, major blood vessels, then we will give you the left gastric artery, gastric reflux, all in that occasion. Okay. Now next discuss is liver. As I told you that the stomach will have to rotate towards left side. Similarly, two buds arises from the developing GIT, from the gastrointestinal tract. One is spleen, the other is liver. These buds, with the development of the tube, the dilatation in certain areas, and the rotation of the tube, the bud related to the liver is being deviated towards right side. Okay, this is a wedge-shaped structure, chocolate brown in color, a major organ of the wedge. This is wedge. Wedge. You see? This is triangular, related to, similar to a triangle. A wedge-shaped structure, and this is chocolate brown in color, soft, self-generating organ. And this structure lies in the right hypochondrium, means this area below the costal margin, and the lower border is slightly below the lower costal margin. Okay? And this area lie in the epigastrium, and this part touches the stomach in the left hypochondrium. So, what is the location? The location is right hypochondrium, major part, some part epigastrium, some part, very little part in the left hypochondrium. So, this wedge-shaped structure is actually, it is responsible for many things. Whatever you eat, this would be digested, this would be metabolized. Whenever it enters into the bloodstream, that will be metabolized. The glycemic control, sugar control, the lipid metabolism, the other metabolism, they are being under supervision of this. So, the next thing, whatever the poisons we are inhaling, whatever the toxins we are getting, whatever the maluse of drugs we are ingesting in ourselves, that will have to detoxify. Detoxify means they will have to be degraded to become harmless. This is being done, this is the function of liver. It will have to do it, so many things. So this organ is lying here, and if you see this wedge-shaped structure in a broad sense, you can see here this is being divided into two lobes. Two lobes. A big lobe is right lobe, a small lobe is left lobe. Okay? The small lobe is left, the big is right. You can see here that big lobe is very much convex. It's convex. You see? Yes. The upper surface, upper area is convex. It touches the cover of the diaphragm. You see? The dome of the diaphragm. And this is being related to the costal margin. So this border is costal, related to the costal margin. This is anterior surface. So all this is anterior surface, and below to it would be a depressions, inferior surface, which is called visceral surface, because so many viscera are closely related to this. You see, so many viscera, they are closely related. The stomach, the pancreas, the intestine, suprarenal gland.
Can you put it again at the stomach, the position of the stomach? Yeah. This is the right position?
Yeah. So, this would be...
attached.
Directly attached?
No, by means of peritoneal attachment.
Visceral.
Visceral bed. So, you see, this is visceral. What is it called? Visceral surface. Related to the viscera.
Yes.
This is sternocostal surface. Okay? And here you can see that there are two small lobes present. Two small lobes. What are those? One, upper one is caudate lobe. What is it called?
Caudate or caudate?
Caudate. C-A-U-D-A-T-E, caudate lobe. The other is quadrangular. This is quadrangular, having four corners, four sides. Quadrangular. So this is called quadrate lobe.
Quadrate lobe, yes.
Another important thing to recall, to memorize yourself, this is the anatomical position, and if you rotate it like this, the upper lobe is C caudate. In English alphabet, C will come first. It should be superior, C. Then Q is inferior, caudate, quadrate lobe. This is C-shaped caudate, this is quadrate lobe. After that, you can see here there is a very important structure closely related to it would be the gallbladder. The gallbladder, whatever the thing is being formed in the liver, it's being carried to the gallbladder by means of the right and left hepatic ducts. So that will enter into the cystic and then into the gallbladder. With the passage of time, whenever it is necessary, the gallbladder will contract and that releases its contents into the second part of the duodenum.
Doctor, what is the spiral valve?
Yes.
Spiral valve.
Spiral
Valve.
You see here, the gallbladder is very, very closely investing to the visceral surface. You see here, and this in front you can see there would be again some sort of same, the reflection of the peritoneum. You see the reflection of peritoneum, one on the left side, one on the right side, and these two layers will have to diverge in both directions on the superior surface. This would be the left, this would be the right. Okay, so this in the middle would be having no peritoneal cover. It is devoid of peritoneum. In between this cylinder, you can see the inside is also bare. No peritoneum. This area is for falciform ligament, which is starting from the back of the anterior abdominal wall, right from the umbilicus up to the liver. It goes up and then it diverges.
This is one of the main structure to
divide the two lobes of the liver. So this is the bare area. Bare areas are very, very important. We usually ask in OSPE about the known bare areas. What are the bare areas of the liver? So this is the area between the two peritoneal reflections. This is again the bare area. This diverges and forms here along with this. Another meets with this reflection of peritoneum. This is a triangular area. This triangular area is called left triangular ligament. Left triangular ligament. What about the right triangular ligament? This reflection of peritoneum forms a crown-shaped structure round about and goes down and unites with the reflection of the peritoneum from the visceral surface. And this will form ultimately a triangular area. This is called right triangular ligament.
Where is it actually the right triangular ligament?
This one is the right triangular ligament, and this is the coronary ligament. Okay? The bare area, the major bare area of the liver. The big bare area of liver lies in the right lobe of the liver. Okay? Closely related to the undersurface of the diaphragm. What else are the bare areas? You see this long tube.
Yes,
inferior vena cava. With the inferior vena cava, it divides the caudate lobe with the right lobe. And in the depth of it lie again the portion of the liver which is found in the depth of inferior vena cava is bare area. No peritoneal reflection there. Gallbladder. You see all the biliary apparatus. This is again a bare area. The peritoneum reflects above the gallbladder, keeping it in its position, very closely related to the undersurface of the liver. And this is undersurface is having also bare area. Okay. The other cystic duct also. You can see here there is a mark here. Whenever a mark like this
is coming in the
exam, what you will identify it like this? What is everybody silent? What it could be? Fundus of the gallbladder. Okay? Fundus of the gallbladder. But if we put a major cross, a big cross in this area, this is porta hepatis.
Where is it?
If I make a cross like this, a big cross, having included the blood vessels, vein, artery, bile duct, all these, if it is included, this would be porta hepatis. So no need to be confused. Okay? Don't mention it, the portal vein, hepatic artery, no. Because we want to know all area, not an individual structure. So usually it comes in exam. Porta hepatis is being repeatedly asked in the exam. If we make a cross here, identify it as porta hepatis. The structures related to it. So the other things related closely to it would be here in this model are not found the important lymph nodes. You see, the lymph nodes, they are present along the porta hepatis in this zone, and these lymph nodes, whenever in cases of malignancy or in cases of infection, what happens that they will enlarge and they will constrict the cystic duct which is being releasing the bile. So that results in obstructive type of jaundice. You see, there are different varieties, no need to mention over here, but due to the presence of this, one thing which is very important for you people, the portal hypertension. Whenever in cases of increased pressure within the portal vein, there would be, you see, neighboring structures get constricted.
Yes.
Number two, due to the increased pressure, the liver gets enlarged, hepatomegaly. Okay?
What about the fibrosis? Yes?
Fibrotic disease of the liver is cirrhosis of the liver. Okay? In cirrhosis, initial phases of cirrhosis like hepatitis C, hepatitis B infections, the liver gets enlarged, inflamed. With the passage of time, there would be, you see, chronic inflammation starts, and that results in fibrosis, fibrotic appearance. That results in mottling appearance. You see, blephs form, bullies form. Some areas elevated, some depressed, some elevated, some depressed. You can see it in your medicine books and all that. So that would be the cirrhotic disease. And finally, these blephs are due to the regeneration, because the liver has got capability to regenerate. So whenever there would be enhanced more problem, that results in compromise and fibrosis. Whenever the fibrosis occurs, it constricts all these structures, resulting in development of ascites, the introduction of fluid, because the blood is entering in, never moving out, so that results in congestion and ascites formation. So this is related to it. One thing which is in the applied aspect due to this is the topography of the liver and the stomach, that is related to it would be the fatty change of the liver. In alcoholics, you can see in the cadavers coming from Germany, most of them, they have got huge liver. Why? Because due to the alcoholism, they detoxifies and ultimately it gets illness. And that results in enlargement of the liver, fatty liver. Hepatomegaly.
Doctor, the quadrate and quadrate, okay, it's located in the right lobe anatomically.
Anatomically. Yes.
What about the physiologically?
Physiologically related to the left.
Why?
Because all the ducts, the acini, they will have to relate with the left lobe. But due to the development, you see the ligamentum teres, ligamentum venosum, all they make a clear demarcation to give their position in the right side. Okay? But physiologically, due to the arrangement of their ducts, they will have to secrete along with the left lobe. Okay, any query?
How many ligaments, Doctor? Can you revise the ligament of the liver?
The falciform ligament.
Yes. Triangle.
The left triangular ligament. The upper border, the lower border. The coronary ligament. The right triangular ligament. Okay, ligamentum teres. Ligamentum teres. This is falciform ligament. This is ligamentum venosum. Okay.
Venosum teres. Coronary.
Coronary is this one.
Again. Coronary واحد ما في left right.
No. Coronary only one. Coronary, no left.
Okay.
Only right side. Because you see, coronary means crown, related to crown. Crown is circumscribed. You see, wide.
Yes.
So this is wide. So this is only one coronary.
I looked into great anatomy. They said anterior and posterior coronary ligament.
Coronary anterior and posterior. This when we put it up like position like this. This is facing anteriorly. This is facing posterior.
But both in the right side.
But both in the right side.
Yes.
No coronary ligament in the left side.
Anterior posterior coronary
Ligament.
ايوه فين التراينجل؟
triangular is ultimately here. Okay, when the meeting place of both.
The meeting place,
Right. Anterior and posterior coronary ligament unite together at the site of right triangular ligament. And in between these, a big area is found which is called a bare area. Do you understand what bare area means? Yes. Because this is not enclosed by peritoneal covering, no visceral peritoneum outside. So in cases of any disaster, any inflammation, this will bulge out more rapidly, this area, compressing more inferior vena cava. Next thing, if you cut major part of the liver in any disease state, if you want to resect it, the small part, after some time, passage of some time, the small part will increase in size. A condition which is called hyperplasia of the liver. Hyperplasia. Two things: hypertrophy, hyperplasia. Hypertrophy like heart. You see, whenever there is more congestion, more venous return, no outside ejection, cardiac failure, you see the heart gets enlarged. This is hypertrophy, in which the size is increased but the number of cells are same. But in case of hyperplasia, the size is also increased and the number of cells gets multiplied, increased. So this is hyperplastic. So it is self-generating organ. So if 1/3 of the liver is functioning, usually the surgeon, they resect the diseased part. Okay? That's it for the liver? Yeah. This is the general topography of the liver.
Function classification for liver right and left lobe doesn't relate to arterial supply.
Does it related to?
arterial supply يعني إنه الحين الكوادات والكوادرات رايت لوب في الاناتوميكال ديفيجن صح؟
Yeah, as he asked.
بس يعني في الفانكشن ما يعتبروا من الليفت لوب عشان الليفت هيباتيك ارتري يغذيهم.
Yeah, I just told you. Mechanically, this is belonging to the right side, but functionally, as it is closely related to the left, and that